Hello, I'm Dr. Betty Maloney. In this Lyme disease awareness presentation, I'll be talking about different types of Lyme cranial neuritis. I chose this topic because these problems are often present, but patients and clinicians may not recognize them as being potentially indicative of Lyme disease. I hope this information is helpful to you. You may be used to seeing pictures of the brain in profile, where you can see the different lobes of the brain, the cerebellum, and brainstem. Or from above, where you see the longitudinal fissure that separates the two cerebral hemispheres. For this talk, I'm directing your attention to the undersurface of the brain, where the cranial nerves are located. The human brain has 12 pairs of cranial nerves, which are shown here. These nerves have different functions, which I'll review in the next few slides. Inflammation of a cranial nerve is known as cranial neuritis. The symptoms of Lyme cranial neuritis are dependent on which nerve or nerves are inflamed. Let's review the functions of the individual pairs of cranial nerves. The olfactory nerve provides your sense of smell. Cranial nerve 2 is the optic nerve. It's involved in all aspects of vision, including color vision and night vision. Cranial nerves 3, 4, and 6, the oculomotor, trochlear, and abducens nerves, innervate the muscles that move your eyes. When one or more of these muscles become weak, it results in double vision. The trigeminal nerve, cranial nerve 5, provides sensation to your face and innervates the jaw muscles involved in chewing and swallowing. Cranial nerve 7 is the facial nerve. It innervates all of the muscles of the face. It also is involved in taste. In Lyme endemic areas, 25 to 50% of pediatric cases of facial nerve palsy are due to Lyme disease. The vestibular cochlear nerve deals with hearing and balance. Cranial nerve 9, the glossopharyngeal nerve, innervates the muscles involved in swallowing. It has branches that contribute to taste. The vagus nerve is cranial nerve 10. This very long nerve is the major component of the parasympathetic arm of the autonomic nervous system. I'll talk more about autonomic functions of certain cranial nerves in just a moment. The vagus has motor branches to the muscles of your palate and larynx. Illnesses that impact the motor branches can alter a person's speaking or singing voice. Cranial nerve 11, the spinal accessory nerve, goes to the muscles that turn the head and shrug the shoulders. The glossopharyngeal nerve innervates the muscles of the tongue. A weak tongue can lead to slurred speech. These 4 cranial nerves are also part of the autonomic nervous system. Changes in pupil size in response to light is mediated through the ocular motor nerve. Inflammation of this nerve can cause light sensitivity. A branch of the facial nerve goes to the salivary glands and promotes the production of saliva. A different branch carries autonomic fibers to the stapedius muscle, which protects the auditory system from noise damage. The glossopharyngeal nerve sends a branch to the carotid body, which plays a role in regulating blood pressure. The vagus nerve has wide-ranging impacts. It's involved in respiratory and heart rates, blood pressure, stomach motility, the sensation of nausea, mood regulation, and the immune response. Malfunction of the vagus nerve can cause low blood pressure, which may lead to a rapid heart rate and the development of POTS, postural orthostatic tachycardia syndrome. This symptom table, which is carried over to the next slide, is derived from Dr. Joe Berscano's careful clinical observations. Items with the yellow star result from abnormalities of the sensory or motor branches of the cranial nerves. The blue stars are symptoms of autonomic dysfunction. Let's look at a few. Many Lyme patients end up in dental offices, thinking they may need a root canal for their tooth pain. Although the medical literature on Lyme disease frequently states that cranial nerve 7, the facial nerve, is the most commonly involved cranial nerve, when I meet with patient groups, numbness and tingling of the face due to dysfunction of the trigeminal nerve is much more common. I suspect the difference lies in what clinicians can actually observe, facial muscle weakness, versus what we can't, altered sensation. The list of visual problems is long. As I mentioned earlier, 3 different cranial nerves are involved in moving the eyes. When one or more are affected, it can cause double or blurry vision. I know one patient who switched to a soft diet because her weak jaw muscles made it hard to chew. If you like, you can pause the presentation to take in the details of this slide and the next one. Here are a few more symptoms to be aware of. Again, the yellow and blue stars. You may have noticed several symptoms relate to the autonomic functions of the ocular motor, facial, glossopharyngeal, and vagus nerves, numbers 3, 7, 9, and 10. These symptoms can cluster in a person. Although clinicians may discount reports of light and sound sensitivities, dry mouth, nausea, dizziness, and racing heart on standing as being unrelated to Lyme disease, when you step back and consider their autonomic origin, such clusters may indeed be evidence of an underlying Lyme infection. A side note on sound sensitivity. Several parents with Lyme disease have told me that they dislike hearing the sounds of their young children when they're happy. That's because the high-pitched squeals that little kids make actually hurt. In my personal experiences with patients, this concern is unique to Lyme disease. This slide and the next review some of the things that clinicians look for on physical exam. Most are easily checked without special equipment, but some, like smell and taste, need items that aren't typically kept in a primary care clinic. The optic nerve is visible at the back of the eye, and we can look to see if it's swollen. Much of the cranial nerve exam has the examiner asking the patient to move various muscles or detect specific types of sensory input, like light touch, vision, or sound. More findings. Many of the symptoms and signs that I just reviewed can be seen in other illnesses and conditions. Because of that, it would be very helpful if diagnostic testing could reliably identify whether or not Lyme disease was the likely culprit. The most readily available tests for Lyme disease are serologies. While it's true that positive serologic testing in a patient with symptoms and signs of cranial neuritis confirms the diagnosis, negative results do not rule out Lyme disease. To appreciate why that is so, one has to understand serologic testing. Serology doesn't identify the infecting pathogen. It characterizes the immune response to a pathogen. In Lyme disease, we are interested in 2 classes of antibodies, IgM and IgG. I think of them as distinct types of responders. IgM is like an emergency responder, being first on the scene in a variety of situations, setting up the potential for cross-reactivity with non-Lyme pathogens. IgG antibodies are specialists. Cross-reactions are possible, but less likely. Of the potential 14 or more IgM and IgG antibody responses that occur in Lyme disease, commonly used serologic tests consider only 3 IgM and 10 IgG antibodies. Positive IgM results must have at least 2 of the 3. Positive IgG results have at least 5. This diagram is a generalized depiction of the timeline and levels of antibody formation. IgM arrives first, peaks relatively early, and then rapidly declines. IgG appears later and has a slower ramp-up period to peak levels. It's important to bear in mind that these are average results and different responses do occur. Here's what we know about responses in Lyme disease. Against the backdrop of the average responses, the medical literature documents that both IgM and IgG can lag behind the average time for antibody formation. IgG antibodies typically hang around for a long time, but in most patients they disappear in a year or two. Statements about Lyme testing that declare once positive, always positive are wrong. In some cases, the IgM response is sustained or recurs, the yellow dotted line. Some never generate a diagnostic IgG response, the red dotted line. For these reasons, diagnostic policies regarding serology that automatically discount positive IgM results after 30 days and IgG results with less than 5 antibody bands will result in Lyme diagnoses being missed. Lyme cranial neuritis can occur early in the course of the infection, and a wide array of symptoms and signs are possible, depending on which nerves are involved. Serology cannot be used to rule out Lyme disease as the cause of cranial neuritis. Because many clinicians are unfamiliar with Lyme cranial neuritis, should you or someone you know develop symptoms and signs of neuritis after potential exposure to black-legged ticks, be sure to mention the possibility. Early diagnosis is critical to having a good outcome. This is a black-legged tick, the only known vector of Lyme disease in the United States. Do all that you can to prevent being bitten, because an ounce of permethrin is worth a pound of antibiotics. Thank you and goodbye.